Yeah, we can see.
Oh, yay. Thanks, Anya. All right, cool. So, hello. This is a bit different. Basically, there's this new thing called Whimsical. I'm not sure if you've all seen it before, but it's like these endless mind maps. And I got really bored with final division, just doing questions. So I thought it'd be fun to make mind maps to try and find new ways of learning. And this is it. So instead of doing like just playing cases, there's going to be a bit of like open questions, and then we talk through what the possibilities are. Pediatrics is very complicated, but it's also quite simple if you just go down to the bare bones of it. Okay, so today we're going to do cardio, and we're going to focus on these conditions. So first of all, we're going to talk about what happens to the babies when they're born, what actually changes happen when they take their first breath. And then we're going to go through the different cyanotic and acyanotic congenital heart diseases and some of their complications. Okay, so a little bit of introduction. Please let me know, or just someone shout if it stops working, or I just don't, it doesn't work, but hopefully it does. Okay, so does anyone want to tell me what the 3 fetal shunts are that a baby has once a fetus has, sorry, not a baby, when they're in development? What 3 fetal shunts they are? They are. Feel free to just post it on this. Yeah, ductus arteriosus, good. Anyone know any others? Sure, ductus, yeah, must be, yeah. Any others? Good. Yeah, I like that. Okay, cool. So these are the 3 that I will talk about: ductus arteriosus, ductus venus, and foramen ovale. Very good. So you guys got all 3. Fantastic. So the one that people always talk about is the ductus arteriosus and foramen ovale. But as you said, there's also the ductus venus. So basically, this is how blood gets from the umbilical vein to the IVC. So it's basically taking all the blood back to the systemic circulation. It normally allows blood to bypass the liver, because if the liver doesn't work out well during development, so it's a good way of getting the blood back to the liver without going through the whole hepatobiliary system. Okay, so it bypasses that. The foramen ovale, I'm sure you've heard about, is a shunt in between the right atrium to the left atrium. This is because it bypasses the right ventricle and pulmonary circulation, as the baby isn't relying on that for the oxygenation of the blood when they're in development. Okay. And then finally, there's the ductus arteriosus, which is from the pulmonary artery. I'll leave this open so you guys can see. From the pulmonary artery to the aorta, and this is so it can bypass the circulatory system. Okay. So these 3 shunts are very important, and some things happen to them at birth. So does anyone want to tell me, going through them, what happens to the ductus venosus during birth, when the baby is born? Does anything happen which causes it to close? Yes, good. So more that is clamped. So let's go through this one first. So clamping of the umbilical cord causes ductus venosus to stop working. Good. Now, the prostaglandins are required to keep ductus arteriosus open. Because we have increased blood oxygenation when the baby takes their first breath, that causes the prostaglandins to go down, therefore causing the ductus arteriosus to close. However, this is quite a slow process. So the ductus arteriosus stops working in the first few days or so, then closes properly around day 7 and 10. And that's important when we get on a bit later to some of the congenital heart conditions which rely on the ductus arteriosus to be able to function as a life form, because otherwise they wouldn't be able to breathe, because there will be no systemic circulation of oxygenated blood. So when it's closed, it has a remnant called the ligamentum arteriosum, which I'm sure you all know. I don't. So that is what keeps close the ductus arteriosus. And then when we take our first breath in, all that increased pressure on the atrial septum on the left-hand side from that first breath causes the foramen ovale to close. It's a functional closer. So this happens quite quickly. The ductus, the foramen ovale, and the ductus venosus. Okay, so let's go down to here. So a patent ductus arteriosus. Okay, so let's open this up. Oh, close that so you didn't see. So when does it normally stop working? Well, we already said about 1 to 3 days from birth, and it closes about 2 to 3 weeks. Okay, so it does take a little bit of time for it to close, unlike the other two, which close quite quickly. So what are reasons it doesn't close? Anyone got an idea why it wouldn't close? Don't worry, you don't. It's very so this is basically it. So prematurity and rubella are the two you need to remember. So rubella somehow causes is a risk factor for patent ductus arteriosus, and prematurity also means that the ductus arteriosus haven't developed either any of the prostaglandins yet to help with maturity of the lung, and therefore that's another reason why it stays open, because they don't have the lung capacity yet. So the ductus arteriosus stays open for those two main reasons, and rubella is a good one to remember for SBA land. Okay, so what happens is there's increasing pressure in the pulmonary vessels leading to pulmonary hypertension. So if we go back to what it is, it's from the pulmonary artery to the aorta. But what's happening now is that the aorta is obviously open and working under a higher pressure. So it's working under much higher pressure than the pulmonary aorta. So there's an increased amount of pressure going through the pulmonary vessels, leading to pulmonary hypertension. That causes significant problems in the right side of the heart. So you get right heart strain and also signs of right ventricle hypertrophy. This is because there's increased blood flowing through the pulmonary vessels, because it's going from, let's go again, pulmonary artery to the aorta, but that doesn't mean that the blood's going to flow that way. Okay. This can also then end up leading to left ventricular hypertrophy itself. So because it's an increased backlog and pressure system, you get this hypertrophy effect. Now, does anyone know what murmur you classically get with someone who has a patent ductus arteriosus? What sort of murmur would I hear? Yes, good. A continuous machinery-like murmur. Very good. I also say crescendo to decrescendo, apparently, but continuous machinery is good. So if it's small, they may not have any other sounds. Okay. So the symptoms you get is that they basically signs of increased respiratory effort, because they have this increase. I'm sorry, that there will be some spelling mistakes, mostly because I did this very quickly. So basically, sort of thing to look out for is signs that the heart isn't coping as well with increased amount of effort there is in the backlog in the pulmonary vessels. So they could have shortness of breath, they could have difficulty feeding because they can't have the air or the capacity to carry on feeding because they just lose breath. And because of that, they have poor weight gain. And also they're more risk of getting lower respiratory tract infections. So they're quite like not non-specific presentation, but that's the sort of symptoms you can get. Diagnosis for all of these is going to be echo. Just remember echo, echo, echo. All babies are going to get echo of any new murmurs which are abnormal. And then management. So how would we manage this patient? If they're presenting with signs of increased respiratory effort, NSAIDs, yeah. Basically, I break it down in conservative and pharmaceutical, so and medical. So we're gonna, for most of them, they're okay. If they're not really symptomatic, because the majority of them are picked up as asymptomatically. You can monitor them for at least 1 year of age using echo. After 1 year, it's very unlikely to close by itself. So what we can do is either you can do a transcatheter surgical closure, but the symptomatic or heart failure patients are treated earlier. And you are right, Chris, you can use NSAIDs, but that isn't like the thing that's normally done. Normally it's monitored to see it would close by itself. And then if it's symptomatic, they can go earlier. But I know what you mean by NSAIDs, because NSAIDs will reduce the amount of prostaglandins, antiprostaglandins that cause closure, which is definitely true. But that isn't technically the management. I don't think they give just ibuprofen to babies. They've got to manage them very carefully and then use transcatheter or surgical closure. But that's if they're asymptomatic. If they're asymptomatic, they will be managed much more earlier. Okay, so let's go down to ASD. So the foramen ovale. Basically, this is a defect in the septal between the two atria. Has anyone got any questions, by the way, about patent ductus arteriosus? I know I'm going slightly quickly. Has anyone got any questions at all? Don't worry if not. I'll just wait a second if anyone wants to say anything. Or okay, I've got the chat open, so if you've got any questions, just pop them in there. Okay. That's a good question. Machinery murmur. So it's kind of like a pansystolic murmur, it's a continuous machinery murmur, but they don't describe as pansystolic because it's kind of throughout the entirety of the whole of the diastole and systole. So if you imagine that, it's like just continuous. So you know how you have systolic and diastolic murmurs? Well, in continuous machinery, it just means that it's continuous noise throughout the S1 and S2. Because it's just basically you're listening to just turbulent blood flow. I'm going not going through a valve, but just going through the pulmonary arteries, which is always under higher pressure. Does that make sense? That's how I understand it anyway. That might not be the exact reason, but that's how I understand it. If you think about it logically, the pulmonary arteries are always going to be at a lower pressure than the aorta. So it's always going to be continuous machinery, like a turbulent blood flow. Another good way of thinking of it is think of it when you get when you do dialysis and you make a connection to an AV fistula, you listen to it, you'll also feel like a machinery murmur as well because of the continuous blood flow. So it's very similar. Okay, so ASD. Again, this is because of a defect in the septum between the two atria. Okay, so does anyone want to tell me, let's just do this, a bit of embryology. So basically, a septum primum is an atrioventricular valve defect. That's because it involves the atrioventricular valves. So the AV septal is a bit higher up. The secundum is because of a patent foramen ovale. Okay. Now, you may hear that in Down syndrome patients, they have atrioventricular valve defects or AV septal defects. This is what they're talking about. It's higher up, but or VSDs, which we'll get onto. But in septum secundum, that's because of patent foramen ovale. So maybe just a little bit of niche knowledge, but I'm not sure it's that important. But it's just for your interest. So what's happening is we have a shunt from the left atrium to the right atrium. Now, is this a cyanotic or acyanotic congenital heart disease? So what I mean by that is the patient going to present with cyanosis? Acyanotic, acyanotic, acyanotic. Okay, good, very good. So, and then someone said, I think acyanotic at birth. Okay, so we'll get on to that in a second, but good. So you're absolutely right. Is a shunt from the left atrium to the right atrium, which means that there is blood going to be shunted from the left side to the right side, because as we all know, the pressure on the left is higher than on the right. Because of that, there's right-sided overload, which means that there's more blood going into the right-hand side and there's right heart strain. So again, similar to when you have a patent ductus arteriosus, you can get pulmonary hypertension because you increase the amount of backlog on the right side of the heart and up into the pulmonary system. And that leads to something called AmazManga Syndrome. Does anyone know what AmazManga? I think it's AmazManga. I actually don't know. I never said it aloud, but AmazManga Syndrome. Does anyone know what that is? Good. So when the shunt is reversed, very nice. Okay. So exactly right. So what happens is this. There's a blood flow from the right side of the heart to the left side across a structural heart lesion. The reason is that there's been a reversal in the blood flow. There's an increased amount of pressure. So pulmonary hypertension causes a reversal to right to left shunt. That means that deoxygenated blood is going to the left side of the heart. Very good. So someone said pulmonary hypertension means reversal left right shunt, therefore cyanosis. Very good. So cyanosis, I could have asked you this anyway. Cyanosis is that there's blue discoloration of the skin. So babies are they have central cyanosis. So you can pick them up quite quickly. It can also be signs that the bone marrow is producing more red blood cells. So if it's chronic, they can have polycythemia. And because of that, they can get a plethoric complexion. So you imagine someone with SVC obstruction, it's sort of the same thing, like red cheeks. I'm not sure about distended veins because that's not exactly what's happening, but a very plethoric complexion. And there's also a clotting risk because there's more blood vessels, there's more red blood cells, it's more likely to clot. Right, so let's go back to ASD because we just got a bit sidetracked there, but good. So complication is that you can get a reversal later on. And here we go. So AmazManga syndrome, AmazManga syndrome, pulmonary hypertension is already said, and atrial fibrillation, because you've got this backflow of blood, so it's going to get signs of atrial fibrillation. And also you can get a stroke. So why is it that you can get a stroke with a patent, with an ASD, a hole between the two atrias? And why have I got VTE there as the cause? Because from my recollection, strokes are caused by more atrial pathology. Okay, good. So common exam question is that you got someone presenting with signs of DVT, swollen calf, and then it gets up all the way up to the right side of the heart. And normally the reason you get a PE is because it then moves off, the embolus moves off into the lungs, up through the pulmonary system. But because there is this hole in the heart, it can, by misfortune, go to the left side and then move up into through the aorta and up into the internal carotid and then to the brain. So it can cause a stroke. So as exactly here, DVT travels to the right side of the heart and then to the left atrium, to the left vein, and then to the brain. Okay. So presentation. Do you know how this will present? We sort of talked about it. So there's a murmur. So the murmur is this mid-systolic crescendo descendo on the upper left sternal border with a fixed split S2. Okay. So this, I never understood this, not even in fourth year. So this kind of makes a bit more sense to me. So we know that there is, when the S2 is a sound, that there is the closure of the pulmonary valve and the aortic valve as well. That's a sound they're both closing. Because the aortic one, I think I have it here. Let me just get it down. I'm pretty sure I have it murmurs. It's a very good explanation. Oh, here we go. Nice. Here we go. What is splitting of S2? So this is when the pulmonary valve closes slightly later than the aortic, as in inspiration. The right ventricle has increased volume and takes longer to empty during systole. So that is because the pulmonary valve is slightly delayed in closing, basically, because there's more blood flowing out through it during inspiration. Because during inspiration, you decrease the amount of intrathoracic pressure and drives more blood back in. But there's this fixed splitting of the S2 because there's this hole in the between the left atria and the right atria, which means that there's blood continuously going back into the right atrium once it's passed through. And that means that there's always going to be more blood on the right side than the left side, in from the right vein and the left vein. So the pulmonary valve will always close later than the aortic valve. And that means that the splitting does not change with inspiration or expiration. That's what it means by fixed splitting. Does that make sense? Does that make sense to everyone? Because that always confuses me what they mean by split S2. So split S2 normally means that the pulmonary valve closes after the aortic valve, but that only happens in inspiration. When it's fixed split, that's because there's more blood going through the right-hand side of the heart than the left. So it's a sign that it could be sign of right-hand side of the heart failure, or also because there's just more blood going through it. Okay? I don't know what it's meant to say. In adult hound, I'm not sure what I meant to say. Oh, in adult, how does it present? So in adults, it can present with dyspnea, heart failure, and stroke. So things that signs of. So can I repeat that? Of course. So let me go up here because you can read it. It's a bit better. Okay. So we're getting in the patent, in the ASD, there's a hole between the left atria and the right atrium. Because of that, more blood is flowing from the left atrium into the right atrium. And because of that, there's this more blood in the right-hand side of the heart, specifically in the right ventricle. The pulmonary valve closes after the aortic valve because there's more blood flowing through it during inspiration compared to the left. The valve can't close until the pressure outside the valve is less than that, is greater than that inside the vein, inside the ventricle, sorry. So that will cause it to close. During inspiration, we increase the amount of blood coming into the right-hand side by decreasing the intrathoracic pressure. That means there's more blood in the right ventricle. because there's more blood in the right ventricle, the pulmonary valve closes later than the aortic valve. So you get a split S2, meaning the aortic valve sound comes before the pulmonary valve sound. You get a fixed splitting in patent ASD because no matter whether you're breathing in or breathing out, you're always going to have more blood in the right side of the heart, meaning the pulmonary valve will always close after the aortic, meaning you'll always have fixed splitting, or you're meant to anyway. Does that make sense? I can send this over afterwards, but okay, cool, nice. If I rush at all, just remind me as well. But yes, okay, so that makes sense to me now as well because I explained it to myself. So in adults, you get signs of heart failure, dyspnea, and stroke, just because you get right side overload. And similar stroke because of, as we said, the hole in the heart. So management of these, if it's small and asymptomatic, we watch and wait. If it's not going to cause much of an issue, there's no point doing very interventional procedures, which is going to put the patient more at risk. So there's a lot of these murmurs, which, as I said, is a mid-systolic crescendo, decrescendo, crescendo, decrescendo on the upper left sternal border. So again, similar position to where the patent ductus arteriosus is. It means that we'll just watch and wait. Normally, these things are picked up when they're asymptomatic. Again, surgically, we can do a transvenous catheter closure or open heart surgery. And because of these patients are at increased risk of stroke via clots, they have anticoagulants in adulthood, but I'm not too sure about what that is. But that's what I had in my notes. Okay, so now that we've done ASD, we're going to go down. So we've done the two of the remnants. So again, ostum primum, ostum secundum. So now let's go on to VSD. Okay. Let me just close this one here and this one here. Is the thing working for everyone? I hope it is. I know this is a bit different to normally. I'm pleased in the feedback. Let me know if this was more helpful or less helpful or just a nice change compared to slides. But nice. Okay. So VSD. This is a congenital hole in the septum between the two ventricles. Okay. So what is a VSD associated with? So remember, patent ductus arteriosus was associated with rubella and prematurity. So that's the sort of things I'm talking about, or not particularly in this situation. Nice. So you do, that is part of the tetralogy of Fallot. Any conditions in particular? Yes, very good. So congenital disorders, Down syndrome and Turner syndrome. We're going to get onto the more specific parts of Turner syndrome later, but Down syndrome patients get these atrioventricular defects. They can either be, as I said in the ASD, they can either be, I've lost it now. They can either be in the ostum primum defects, or they can be here VSDs, more commonly VSDs. So VSDs, acyanotic or cyanotic? Good. So these patients are acyanotic. And what murmur do you get with VSD? Anyone know which murmur we would have in VSD if it was to be picked up? So pansystolic. Okay, nice. So on examination, the murmur would be a pansystolic at the left lower sternal border. What else causes this? I actually don't know what I wrote here. Does anyone know what else causes a pansystolic murmur at the left lower sternal border? I actually don't know either. I can't remember what I wrote here. Let's have a look. Oh, right. Okay, I did know that. MR and TR, fair enough. Fine. So mitral regurg and tricuspid regurg also can present here, but they would present. Okay, fine, fair enough. But they were ready to the apex. All right, fine. I thought it was like other congenital heart diseases, but fair enough. Okay. Mitral regurg and tricuspid regurg, very good. Also have pansystolic murmurs. Fine. So in VSD, the murmur you get is a pansystolic murmur, exactly like tricuspid regurg and mitral regurg. So let's go through this. So it's a congenital hole in the septum between the two ventricles. It's linked to Down syndrome and Turner syndrome. So you do normally get a left to right shunt because of the increase in pressure. But again, this right-sided overload and right heart failure increases the flow into the pulmonary vessels. And because of that, you get this pulmonary hypertension. So you are seeing a sort of link here. If there is increased pressure on the right-hand side, the end result will be pulmonary hypertension of some kind, right heart strain, right side of the heart failure. AmazManga Syndrome does occur again because of the same reason we talked about in ASD. And the symptoms that these patients present with, again, think about any kid, baby who has their heart isn't ticking the way it should be, the oxygenated blood isn't getting around, is going to present with signs of respiratory increase in effort. Children don't tend to have cardiac problems in the sense that that's how they present. They tend to present with signs that they aren't breathing as well as they normally would do. And that can also be how they present with cardiac stuff. And what I mean by that is this how they present here. So poor feeding because they're just not getting the oxygen to their blood when they're feeding. So they're struggling to continue feeding from the breast because they're having to take increased draws of breath. And that's when you see that head nodding with increased signs of respiratory effort, okay? Dyspnea and tachypnea, so increased respiratory rate. And because these patients also have failure to thrive, okay? So we talked about the panstonic murmur here. Treatment for these, watch and wait, again, surgical closure by the same means. And these patients do have increased risk of infective endocarditis. Different things say different things, but apparently there's some do get prophylactic antibiotics, but I know that's not always the case. So it depends on local guidelines and regulations. Okay, so that's VSD and ASD. Now, someone mentioned tetralogy of Fallot, everyone's favorite congenital heart disease. Does anyone want to tell me what are the tetralogy of Fallot? Overriding aorta, good, that's one. VSD, nice. Yeah, pulmonary stenosis, good. Yes, and right ventricular obstruction. So we'll go through that. So you get VSD, we talked about, that allows blood to flow between the ventricles. You get this overriding aorta, and I'm not sure if anyone has ever seen what that actually looks like. It just means that the aorta is placed slightly over to the right more than normal, above the VSD. Basically, that means that if we think about the three things here, you get pulmonary valve stenosis and right ventricular hypertrophy, basically as a result of all these things going on. Okay, so which of these four things correlates with the severity of the condition and the earlier that they present? Besides the VSD, the amount of right ventricular hypertrophy, the overriding aorta, or the pulmonary valve stenosis? I'm not sure as any people will reply to that. Stenosis, right ventricular obstruction. Okay, so it's the amount of pulmonary valve stenosis. And the reason for, maybe that's what you have meant by that, by the right ventricular obstruction, but pretty much the pulmonary valve stenosis. So what is happening is that if you think about it this way, you have an aorta, which is closer to the, which is above the VSD and is closer to the right side than the left side. When you have blood being pumped by the right ventricle, it's going to adopt the approach that I want to follow the direction of the least amount of pressure. If there is such significant pulmonary valve stenosis that more blood wants to flow up through the aorta rather than through the pulmonary valve going through the right ventricle or across through the VSD, less blood will be oxygenated. More blood will go from a right to left shunt. And that means that if the pulmonary valve stenosis is greater, you have more cyanosis, which makes sense, right? So risk factors for this, rubella, increased risk of congenital heart disease overall, increased age of the mother, alcohol consumption in pregnancy, and diabetes. I think just general things to remember. Investigations, we're going to echo them. We're also going to do a chest x-ray. I mean, are you going to do a chest x-ray on a baby? Probably not. But if we were to do a chest x-ray on a baby, what would the heart look like? Does anyone know the classic pass med sign? Well, not really pass med sign, that's not really fair. Pass med. Anyone know what the sign is you see on chest X-ray for tetralogy of Fallot? Boot-shaped, yeah. A boot-shaped heart due to right ventricular thickening because of right ventricular hypertrophy. And on the echo, we will do some Doppler flow studies to see how much blood is flowing into the right side or to the left side. Okay, nice. Has anyone got any questions so far on tetralogy of Fallot? Anything I've mentioned so far about it? I think it's just remembering the four. I've never found a way of remembering the four. I just cut to kind of work out the pathology, and then it kind of makes sense. VSD is one I always forget personally. But yeah, I'm sure there are some mnemonics out there. Okay, so these patients will present with an ejection systolic murmur caused by the pulmonary stenosis. I suppose they could also have a pan-systolic murmur for the VSD, but I think the ejection systolic murmur is the one that is loudest. They could have severe cases present with heart failure before 1 year of age. Okay, so as I said, the severity depends on the amount of pulmonary valve stenosis. So these signs and symptoms are quite increased. So you get cyanosis because, so tetralogy of Fallot, is it an acyanotic or is it a cyanotic congenital heart disease? So you're all quite happy on the ASD and VSD. Which one is tetralogy of Fallot? Was that an unfair question? Cyanotic. I think it's an unfair question personally. I think that it depends on the severity of the pulmonary stenosis personally. I'm sure they'll be grouped under cyanosis, but a lot of these patients, depending on the size of them, they won't actually present for a while. So there are a couple of cyanotic heart diseases which present from birth, and we'll talk about that one in a minute, which is the transposition of the great arteries. But the tetralogy of Fallot can actually, after quite a few while, can actually not present for quite a bit, and that's because of if the pulmonary stenosis isn't that great, then more blood will be oxygenated, and also you can have a patent ductus arteriosus, which is important. Okay, so cyanosis would happen though, so I think it is a cyanotic disease in fairness. You do have clubbing, poor feeling again because of the increased respiratory effort needed to oxygenate, so they're going to have poor feeling because of that. Poor weight gain, an ejection systolic murmur, and they get these TET spells. Has anyone heard of that or know what that is? Or how they would present? How would someone present if they had a TET spell? Anyone got any ideas? Yeah. So basically, this is when the child becomes very irritable. And when they become irritable, they just don't breathe when they're coming in. And because they're increased risk of getting cyanotic anyway, they get these symptomatic periods where they get from a right to left shunt because of temporally worsened amount of respiratory effort. And then there's basically like a cyanotic epinode. So this happens when the child is physically exerting themselves. And they tend to present with they generate this CO2 themselves. So because they're generating all this CO2 by physically exerting themselves, by crying or by running or just by walking very quickly, CO2 is a vasodilator and it causes systemic vasodilation and therefore reduces the systemic vascular resistance. So because of that, the systemic vascular resistance, that vascular resistance through the aorta is lower. So it's even less than through the pulmonary stenosis. So even more blood goes to the right, goes from the right to the left compared to the up through the pulmonary system. I'm not sure how that is, but that's apparently the theory. Okay, so I can repeat that because I know I rushed that a little bit. The child exerts themselves by crying or by just running around and playing. And because of that, they generate CO2 because of increased amount of effort they're doing. And then that CO2 causes vasodilation, decreases resistance on the systemic circulation. And that means that more blood is able to follow the path of least resistance and skip through from the right to the left, bypassing the pulmonary system, and you get this cyanotic spell. Okay, how do we manage these patients? So some of these patients, I'm not sure why I say there's plenty up here. They have this sort of squat position when a TET spell occurs. Basically, they squat down, and this is because they're increasing their systemic vascular resistance and encourage blood to enter the pulmonary vessels compared to the aortic. So that's why they're doing it. And the younger person may do the same thing, but bring their knees up to their chest. So you might see that in an SBA sort of description. So management of these patients, we're going to give them oxygen, obviously. A, B, C, D, E approach. Beta blocker to relax the right ventricle, to allow more blood to just basically calm down the guy or girl. And IV fluids, you want to increase the preload, increase the volume of fluid flowing through the pulmonary vessels. You can give them morphine, decrease respiratory drive, resulting in more effective breathing. So you need to calm these patients down. They're crying, becoming even more blue, and it's just a vicious cycle. Sodium bicarbonate, I mean, I've never seen it given, but apparently you can give it to buffer any metabolic acidosis which is occurred from anaerobic respiration. And also you can give a phenylephrine infusion to increase systemic vascular resistance, which is what the problem has been. Okay. I think there is a mnemonic, but I couldn't find it. I had a really good one last year, but I couldn't find it. So if anyone got it, if you want to post on what the mnemonic is on the group chat for everyone else. But basically think of it in two different ways. Think of it, I want to calm down the guy, the baby. I want to increase the preload to get more fluid flowing through the pulmonary system. And then I want to calm them down, decrease the respiratory drive to allow them to breathe more effectively. And then also I want to increase vascular resistance to allow more blood to flow through the pulmonary system. Okay. Has anyone got any questions on TET spells or what they are or management for them before we move on? Oh, there's another one here about, we haven't finished exactly on TNF. I'll put that up here. So this is important. A lot of these cyanotic or acyanotic, a lot of these cyanotic conditions rely on the ductus arteriosus. And the reason being for that is this. I'll just go back to the ductus arteriosus here. So the ductus arteriosus is allowing blood to flow from the pulmonary artery to the aorta, basically meaning that blood is able to flow straight from the pulmonary aorta to the artery. So it bypasses the circulatory system. Without that, there'll be no mixing of blood or reduced amount of mixing of blood. And that's very important. So we need to give prostaglandin infusion to maintain the DA. And prostaglandins, as we remember, go down when we take our first breath. And because of that, it causes the closure of the ductus arteriosus. And then that buys us time, allows mixing of blood to occur. And then there's a total surgical repair by open heart surgery, if it is found. Okay, so that is tetralogy of Fallot. I'm wary of the time. It's 40 minutes. I've been through the two here. I think let's focus on, let's go for one that's going to come up. Let's go for coarctation of the aorta. Okay, has anyone got any questions on tetralogy of Fallot before we finish on coarctation of the aorta? No. Okay. So, coarctation of the aorta. Let's talk this through. So, what is it? What is coarctation of the aorta? Good. So, narrowing of the descending aorta. I think that's pretty fair. Yeah. Congenital narrowing of the aortic arch around the ductus arteriosus. Okay. So, when I say preductal and postductal oxygen saturations, what am I talking about? And how do you measure preductal oxygen saturations? So where is the narrowing? So the narrowing is basically, it's just above like where the aortic arch is. Got you. Fine. If there's a difference between the coarctation, fine, perfect. So it's working out whether it's before the ductus arteriosus or after. Perfect. So you measure the right arm, and the right arm will show the preductal measurement, because if you remember from anatomy, you've got the brachiocephalic on the right side, the right brachiocephalic, and that then supplies the blood for the right arm. And then after that you have the pulmonary system, the aortic branch, and that supplies blood for the rest of the left side and the right leg as well. Okay, so the right arm will give you the pre-ductal measurement. And then if you compare that with the left side, so the left duct, but the post-ductal measurement, if there's a difference, you can say that there is a difference between the amount of oxygen getting there, and that could point to coarctation of the aorta, okay, if it's happening before or after the ductus arteriosus. Very good. So what is it associated with? Which congenital condition is coarctation of the aorta associated with? Yeah, Turner syndrome. Very good. So Turner syndrome is classically associated with coarctation of the aorta, but also VSD. But the one that is classic is Turner syndrome here. So what happens? So the reduction of pressure of blood flowing to the arteries that are distal to the narrowing, but there's an increase in pressure proximal to the narrowing. So the first three branches. Okay. These patients, they present in the neonates. So in the neonates, what they'll have is a weak femoral pulses, which is picked up during a neonatal examination when they're born. So they measure the femoral pulses, and then they see whether or not how weak they are, how strong they are, and then also if there are any murmurs at all. So you perform a four-limb blood pressure, and then if there's a high blood pressure in the limbs applied from the arteries that comes before the narrowing, and there's a low blood pressure in the limbs that come after the narrowing. There's also a systolic murmur. Could I zoom in, please? Yes, sorry. I'm sorry about that. So there's a systolic murmur heard below the left clavicle. And there's also tachypnea, again, because increased amount of respiratory effort, poor feeding, and a grey and floppy. I'm pretty sure I meant to say floppy. There we go. Grey and floppy baby. So these babies can be seriously, they can get quite cyanotic. And they can present quite grey and floppy, and that's what you should be looking out. So if you remember your AGPAR score that you do for pediatrics, you look at the colour. So the colour of the baby, if they're blue or if they're grey, and also their tone. So that wouldn't be good. So what signs may develop over time? So basically, it just correlates to the problems where you're having. So a left ventricle here to left ventricle hypertrophy, because the left ventricle is contracting against increased amount of pressure, and you will also get undeveloped left arm and undevelopment of the legs because you get a less amount of blood being supplied to those extremities. So the management of these, if there's critical coarctation, you want to give prostaglandin E to keep the ductus arteriosus open. If you keep the ductus arteriosus open, that means that more blood is able, if it's preductal, to get down into the systemic circulation. Allows more mixing of blood. Allows some blood flow through the DA to systemic circulation distal to the coarctation. Good. And then I didn't actually write out what we do afterwards, but I think I actually can't remember, I'm sorry. But I think with these patients, it will depend on how they present. And then again, you can do catheter valve replacement possibly as well, or problems with the valve themselves. Okay, so that's coarctation of the aorta. That is 45 minutes. I think that's good. We can quickly talk about the transposition of the great arteries very, very quickly. This is cyanotic. This is the difference between these two and tetrangiocephalus, which does get confused sometimes, is that TOF can present later. Transposition of the great arteries will present at birth. The reason is that there's switch between the aorta and the pulmonary trunks. So the right ventricle pumps blood into the aorta and the left ventricle pumps into the pulmonary vessels. Complete switch around. So associated with these sort of things, so VSD, coarctation of the aorta, pulmonary stenosis, so this can happen. And after birth, you get immediately life-threatening, as there's no connection between the systemic circulation and the pulmonary circulation. So they are cyanosed. The only way that there really is life is that there is a shunt between the systemic circulation and the pulmonary circulation, a PDA, ASD, VSD. They'll present just within a few weeks, the shunt will close. So as I said before, the shunt tends to close around day 3 or 4, or begins to stop closing immediately once you take the first breath of life, but it can last up to 14 days. So these patients can present a bit later, but they tend to present early enough when the patent ductus arteriosus stops working initially. And when they do, again, you see a common theme there. Cardiac things present with respiratory distress. Tachycardia as well, poor feeding, poor weight gain, and they can sweat as well, these babies. So we're going to give a prostaglandin infusion. I think that meant to say infusion, to maintain the ductus arteriosus. We're going to do balloon septostomy, open up the between, I think it's between the ventricles, but I might be wrong. And then open arc surgery is the definitive, spelled wrongly, management. It's called an arterial switch, and I have no idea what it is, but that's what they do. Okay, and I presume it means that they just switch around the artery, switch around the valves, and give and the big vessels, and allow these babies to properly function. Okay, cool. So we've gone through quite a lot. I missed out a couple of things which are a bit more niche, but I think I've been through the proper big ones. The big ones you'll see: patent ductus arteriosus, coarctation of the aorta, VSDs, tetralogy of Fallot, and transposition of the great arteries, and also how these patients tend to present and manage. Okay, does anyone have any questions at all? Yeah, any questions at all before we finish? Or want me to open up anything from before or clarify anything I've said? Okay, nice. Fine. I think we'll call it there. No worries. Okay. So the split S2. Okay, it confuses me as well, so don't worry. I'm still confused by it. So S2 is the pulmonary valve and the aortic valve. I'll stop this. Makes it a bit easier. Okay, there we go. The split S2 is the pulmonary valve and the aortic valve. The S2 correlates them closing. The pulmonary valve tends to close later than the aortic valve when there's more blood flowing through it. It just makes sense, right? If there's more traffic going through one of them than the other, that other one is going to finish later than the other one. So during inspiration, when we breathe in, more blood is flowing through the right-hand side. That's why we measure right-sided murmurs with inspiration and left-side murmurs with expiration. Breathe in, breathe out, because there's more blood going through it. When we have an ASD, or anything which allows more blood to flow to the right side, that will mean that the pulmonary valve has more traffic going through it, because there's more blood going from the right atrium to the right ventricle up into the pulmonary valve. Okay? The aortic valve would always close first, regardless if you're breathing in or breathing out. It just happens. Therefore, we have a split S2, and it means a fixed split S2, not just a split S2 during inspiration. Okay? I hope that makes sense. That's the way I understand it. It just means that there's more traffic going through the pulmonary valve than the aortic valve, therefore it'll close less. Yes, exactly. So you should normally get splitting during inspiration anyway, because there's more blood going through the right ventricle. Or, well, that's what cardiologists tell us when we are on the wards, don't they? Whether it's true or not is the case. But physiologically, that should happen. So that's the reason why it happens. So the reason it's pathological here is because it's fixed. It doesn't change with inspiration or expiration. It's happening all the time because there's constant amount of blood going to the right side of the heart. Okay? No problem at all. All right, guys. Thank you very much. Oh, nice seeing Nusha's turned up again. Thank you all, and I'll see you guys soon. And anyone got any questions at all? Which app? So it's called Whimsical. I'll type it here. Whimsical. I spelled it right. I think so. But put that in. So Whimsical, basically, you can get it for free if you sign up for it with as your student login. So it takes a while, but at the moment you get like a free version, and then you can sign up for a free with Whimsical. I really like it. I only discovered it this year. All right, guys. See you later.